It's a great honour for me to be here. It's also a great honour for me to be sharing the platform with these guys, although I am a little bit relieved to be going first because they are hard acts to follow. My name is Cam, and I am Canadian. And I say this not just so as to ingratiate myself to you, but more as a bit of a warning, you see, because I associate being Canadian with being polite and being positive. But from time to time, this gets outweighed by two other sort of darker sides of my makeup, being Scottish and being an economist. And it's not a good combination, and it can easily lead down the path of misery and miserliness. And that critical side of me tends to come out when faced with wave after wave of healthcare reform or trend in healthcare management. And I tend to my starting point is to kind of label them as gimmicks. And gimmicks, of course, tend to deflect us, I think, from what really matters which for me in the health arena and as a health economist is threefold. Good structures, especially when healthcare is publicly funded, and we don't want those structures and associated incentives or disincentives to cause waste. Recognising and managing scarcity, which requires good management process for doing that very difficult task. And of course, the need to focus, particularly in mature societies and systems like ours, on health determinants rather than health care, as that's likely, in my opinion, where the big gains are now to be made at the margin with respect to health. Now, although that might sound like my own personal triple aim, slightly adapted for publicly funded healthcare systems, my contention is going to be that the real or actual triple aim as adopted by our systems so far is somewhat of a gimmick by my definition and by these three criteria. And of course, what I'm going to do is attempt to explain my position on that in the context of healthcare in Canada. So hopefully that's going to fire up debate more than trying to answer directly the questions posed in the programme, because it would be very easy to say that health economics and triple aim go very well together. They do. In principle, we've seen great examples of that at the conference so far, and of course several attempts at the conference, successful attempts in trying to make the triple aim work even better on an ongoing basis. Anyway, just to remind us of the original dimensions of triple aim, the contention, of course, is that the focus should be on population health, patient experience and cost. Sometimes the last is adapted to a broader concept of value for money. And despite it being very difficult, of course, on the face of it, to argue against such a framework and the practical initiatives that then engenders, like patient-reported outcome measures, trying to implement notions like lean thinking, the originators of triple aim themselves discussed several required antecedents, so things that obviously need to be in place for the initiative to work at its best potential. So using the words of the triple aim originators, on the structural side, these things might be rational collective action, which of course is engendered and related to greater integration. At gross levels of comparison, I think one can see why the originators of triple aim, coming from the United States, would spot such crucial factors. The US system, or at least large parts of it, sorely lacks in integration and the ability for rational collective action. And again, at the gross level, it's easy to go on and think that systems like that in the UK and those in the Canadian provinces and territories are better suited to schemes like triple aim. It's almost as though we think the very act of publicly funding healthcare makes it easier to adopt these types of scheme, when in fact the issues, I think, are much more subtle, but still nevertheless large and important. So with all that in mind, by way of background, I want to address three such issues in the remainder of my presentation. And again, although we've seen various degrees of progress against each of those three issues that I'm going to raise, I still think that the critique still stands to a large extent. So the first issue, or as a question, is where is the integrator in Canadian healthcare? This is a question that's been asked by many policy analysts for decades. At different points in time over recent years, between 20 and 25% of our health expenditures come from the private purse. That's not integrated, and it means we should always beware fellow Canadians claiming that our healthcare system is single-tiered. Only physician and hospital services can just about claim to be single-tiered. But even, as we've seen from examples at the conference, they are fractured when we look within the publicly funded parts of the system. Physician remuneration relies on a predominant payment type, fee-for-service. The physician payment pot is then run as a separate system, and primary and secondary care are not integrated either. Now, of course, we can rely on professionalism, communication, good leadership, but what I'm saying is that these things are not integrated structurally in a way that makes alignment with the triple aim that obvious. In the UK, where I come from, we don't suffer to the same extent from such challenges, but just as we have to be aware of Canadians lauding their healthcare system, we have to be equally aware of those espousing the virtues of our beloved NHS. The greater integration that might exist from NHS-type systems is necessary but not sufficient, I think, for schemes like Triple Aim. So take, for example, quality improvement schemes more generally. The evidence, I think, on which shows their operation in NHS-type systems is not as successful as one might think. There's a well-known comprehensive review for the Health Foundation in the UK, authored by John Ovredveit of the Karolinska Institute, published in 2011, shows that despite lots of evidence on the costs of uncoordinated care, there is correspondingly a weak evidence-based base for actual solutions based on clinical coordination and quality improvement initiatives. Alan Maynard and Karen Bloor from the University of York, in one of their normally controversial papers published in the BMJ in 2010, show that the NHS Quality and Outcomes Framework came at an estimated cost of £1 billion, with very little evidence that the health outcomes justified such an expense. There were no controlled studies, and there's no evidence on the opportunity costs in the sense of what is displaced due to paying attention to the targets required by the focus on quality. Some of these points are illustrated, I think, more qualitatively by the fact that scandals in the UK NHS just keep on coming. Only in March of this year, when the CEO of the NHS, Sir David Nicholson, was interviewed by the House of Commons Health Committee about the lack of response to data on excess mortality in Mid-Staffordshire NHS Hospital Trust, his answer was that, quote, "The data do not tell you how many deaths are avoidable. Going from excess deaths to being able to say they are avoidable is a big step. The numbers being indicators to go and look," unquote. To which the MP questioning him replied, quote, "But nobody did," unquote. So NHS-type systems, I think, can be portrayed as stumbling from funding crisis to funding crisis. Indeed, I think we could just say that the UK NHS has been in one funding crisis since 1953. That's when the first inquiry into NHS and related expenditure, what's known as the Guilbeault Commission, was established, which led to the economist Brian Abel Smith, later a professor at the London School of Economics, being employed to characterise the nature of the problem and potential solutions. Incidentally, we could say that was the beginning of health economics in the United Kingdom. Since then, in sort of broad terms, the solutions have tended to be in one of two forms. The first one is bailouts, which actually give incentives to the system to overspend, but not by too much. And more depressingly, nothing seems able to stop the inexorable march of patients into the most expensive part of the system, the black hole of the acute sector. And indeed, there are often powerful incentives for that to happen. In Canada, the disconnection between primary and secondary care doesn't help, whilst in the UK, we've tended to have weak purchasers or commissioners coupled with strong providers, reinforced by payment for each case admitted to hospitals, and large privately financed capital projects in the acute sector to pay off. And the only way of doing that is to suck more people into the system. The second solution is more gimmicks, usually labelled as some type of reform and accompanied by platitudes such as, "We will adopt a balance of care approach. The new system will be about effectiveness and efficiency, and it will adopt an evidence-based approach, involve communities and other stakeholders." These statements could come from any government document on any healthcare initiative in any country of the world. The problem being that they come with no process attached. How is balance of care going to be achieved? How is evidence on effectiveness and efficiency going to be incorporated into day-to-day management processes? Some health economists sign up to such reforms and some the opposite. So in the case of Triple Aim, it's hard for a single economist like me to be definitive as to the place of the discipline in doing what is right in supporting such an initiative, because these are things that we contend and that we argue about. So some see opportunities, whilst the curmudgeons, like me, Scottish health economists, only see the opportunity costs. However, this is all a rather long-winded way of leading me to my second issue, which is that what such reforms continually tend to do is to create entities that have to manage scarcity without supporting the people that work in those entities in the processes required to undertake that task. And that's an area where I think health economics itself has not done that well, despite great work that health economists do in areas like health technology assessment, etc. So what are required then are processes that facilitate decision-making that matches resources to needs, recognising that what is available will always be outstripped by the claims being made on those resources. And if we recognise this, then we have to accept that we need to better manage scarcity. And if we accept that, then any level of the system at which scarcity bites, 5 questions about resources apply. And these can be portrayed, if we like, as, say, let's call it an economics approach to needs assessment. The questions obviously listed on the slide. What resources do we have in total? How are those resources currently used or spent? Then the easy question, what are the candidates for more resources, and what's the evidence with respect to them? That might be characterised as our wish list, or often of service developments. Are there any areas of care which could be provided to the same level of effectiveness but with less resources, so that in a fixed funding envelope situation we can release those resources to fund some of the things near the top of our wish list? That's the kind of the technical efficiency question, if you like, in economics jargon. And then logically, if we're maxed out in terms of technical efficiency, we have to ask the allocated efficiency question. Are there areas of care which, despite being effective, should have less resources because something on our wish list is actually more effective for the dollars required? And that set of questions can be applied at micro or programmatic levels, or in principle they can be applied across such programs. And project management schemes have been developed for implementing these questions in ways that take account of planning cycles of health regions and can be meshed with ethics-based frameworks. And there are now various examples of successful development and sustained use of these schemes based on answering these types of questions, especially here in Western Canada and the prairies. The framework incorporates notions like lean. I mean, lean, in a sense, is part of the technical efficiency question number 4 on the list. But its essential feature is that through extensive qualitative research led by researchers here at the University of British Columbia and previously in Calgary. It's been formulated as a process that can be embedded into management systems. So in a sense, what it's trying to do is turn the adoption process for health economics on its head by trying to understand management systems and cycles and make the economics frameworks like this fit those cycles so that opportunity cost becomes a constant part of the debate and even central to decision making. It goes further than triple aim in the sense of it allows broad sets of criteria to come into the debate, like equity, for example, and of course the allocative efficiency question, which I'm not sure triple aim really faces up to. My third and final issue rests, of course, with population health. Now here, I'm not an expert, and strictly, I can't speak for Canada. You know, but I've never been to Afghanistan, and I've got a view on that. So I'm kind of, and as I've got the floor, I won't let it stand in my way. So what I'll do is I'll throw out a few speculative challenges to us, I think, as a health research community. These being as follows. So first, I think the term population health worries me in the sense of its potential to actually take us away from public health initiatives based on complex notions of community. So, for example, in the UK, the term population health has been hijacked by organisations like the Medical Research Council, very prestigious research funders, resulting in more and more epidemiological evidence continually refining the diagnosis. It's great work. But if it leads anywhere in terms of solutions, it's usually to a focus on those that can be characterised as products chasing diseases. Some sort of pharmaceutical or technology-based solution often centred around personalised medicine. Or it gets as far as solutions based on acting on individual risk factors like smoking, alcohol consumption, diet, exercise. So whilst all this world-class public health research is going on, and various quality initiatives are perhaps improving our publicly funded healthcare systems, health inequalities, at least in the UK, I can't talk so much for Canada, health inequalities in the UK continue to grow. The latest work of the great Sir Michael Marmot showing only in 2010 that the difference in life expectancy between best and worst off in my own and home city of Glasgow is now as high as 28 years. It's not a problem of austerity in the broad sort of macroeconomic sense. It's a problem that's been getting gradually worse over a long period of time. So something is not right. And it seems to me, of course, and you'd expect this kind of suggestion, is that the clues lie in our continued lack of ability to move upstream. So if it's hopelessness, exclusion, lack of connectedness that kill people, then we need to work on these, the causes of the causes, an upstream agenda which I would contend is not best served by investing more in the healthcare system. The US system, coming back to triple aim, the US system might be able to generate significantly improved population health via reform, healthcare reform and adoption of schemes like triple aim, because it's so inequitable in the first place. But I'm just not convinced that that same logic applies here in Canada. Right, now I have to go back to invoking the Canadian in me and finish a bit more positively, though not necessarily politely. So what would I suggest then after my little mini rant? Well, again, some of these answers are very obvious. We need a healthcare system fit for 21st century needs. Going back to Overitveit, he shows how that can be done through better coordination of services and managing chronic disease where patients want to be, in communities. This requires, as we saw so eloquently outlined by our Emmett Hall laureate Brian Hutchison yesterday, a redesign of primary care, greater integration and reform of payment mechanisms. It also, I think, has some unspoken implications for the acute sector in various countries, but we can leave that for the discussion part of the session. We know that scarcity can be managed, recognised and managed, even in quite politically complex systems. Managers need permission to get on with this, working in conjunction with the health economics community, as we still have a lot to learn from each other. I believe if we don't do that and make that connection, it actually poses a threat to our publicly funded healthcare systems. If we want to improve so-called population health, then obviously from what I've just said, I would of course suggest that we need to think differently about how to do that and continually evaluate consequent interventions and policies. If the Triple Aim gets the job done in progressing these issues, that's fine. Personally, I think the way Triple Aim is portrayed and enacted now might focus us and our research funders and foundations too, incidentally, too much on quality improvement within current structures. And whilst quality appears to improve within those structures, it leaves the opportunity cost of this and the real potential gains which could arise from what we really need to do unrecognised. Thanks very much.